Hi everyone, this is Ashton with Haynes Physical Therapy. Thank you guys for coming on to our low back pain and sciatica workshop, virtual workshop. I just wanted to cover a couple of things really quick. Throughout the course of the workshop, if you have any questions, down at the bottom of the screen there's a Q&A button and a chat button. You can use either of those and the questions will come directly to myself and to Casey, who is also on with us. And we would be happy to answer them or have Dr. Haynes answer them live. Also, you should have gotten, no, sorry, we didn't do that this time. So that's it. Now I'm going to turn it over to Dr. Haynes, and he is going to take us from here.
All right. Thank you, everybody, for, first off, can you hear me fine? You dropped out.
I can hear you. Yeah.
Okay. Thank you very much. So thank you, everybody, for coming on board to listen to me talk a little bit. Low back pain and sciatica. Again, we normally try to do these during a live situation where folks come into the office and we do some live demonstration and so forth. Now, the good news is in a couple of weeks, I think we're going to be able to safely do that again. So we may still have some of these virtual through the computer, through the phone workshops, but I look forward to getting folks into the clinic for our workshops here really soon. So if you don't get what you learned from this, just pay attention and we'll have more information coming soon. But let's get right into the nuts and bolts of this. First off, I'd ask, has anybody had back pain or sciatica in the last 30 days? I always say that I'm a member of the Back Pain and Sciatica Club myself. And so I always raise my hand when I ask that question. So during the past 30 days, the big question is your back pain reproducible? In other words, are there things that you do during your day or when you're, maybe it's while you're sleeping, maybe it's lifting, maybe it's a number of different things, but is there something that you did that seems to reproduce that pain? We'll talk about it a little bit later. As a therapist, that's one thing that I really look for is what is the action that causes that pain? And so again, what were you doing when you had that pain? So while we're going through this, I want you to just think back and try to see if you can pinpoint what it was that you were doing. And when you did that, how bad was it? Was it, so we use the 0 to 10 scale or the 1 to 10 scale. 1 is, next to nothing as far as pain. 10 is worst imaginable. When your pain was at its worst, how bad was it? I can say my back has actually been pretty good the past month or so. So I probably haven't had anything over a 1 or a 2. So I'm not overly concerned about that. I do know when mine happens. It's usually worst whenever I'm trying to get out of bed in the morning. If I'll do my stuff that I need to, my little exercises, it'll be okay. But frequently I don't do that, so I'm also a bad patient sometimes. So those three things: is your back pain reproducible? What were you doing when you had the pain, and then how bad was the pain on that 1 to 10 scale? So let's talk a little bit about the word sciatica. So sciatica is a weird word. Really and truly, it's not a medical definition per se, or a medical term per se, because it really doesn't identify anything. For the sake of our discussion, we're going to call sciatica, and we're going to refer to it as pain that originates in the back and then travels down the leg. It can be the back of the leg, side, the front, but that traveling pain is what we're referring to as sciatica. So to talk about sciatica, we have to talk about the sciatic nerve. So the sciatic nerve is made up of 5 different nerves. They come from the fourth lumbar vertebra, which sits right about here. And you can see the different branches that make up the sciatic nerve. So at L4, L5, S1, 2, and 3, all of those nerves come together to form the sciatic nerve. And so they're all right there. And as you can tell, we're going to look at it from the other side. That sciatic nerve is pretty big. It's a little bit smaller than the size of your thumb as it exits right there. But important to know about the sciatic nerve is it travels from the back right through there, and it comes out the back of the pelvis, or what we call the sciatic notch in that region. And then it runs between what we call the sit bone, that bone right on the bottom of your behind that we sit on in any chair. I'm sitting in a hard chair right now, so I feel my sit bone. So it comes out between the sit bone and the upper leg. So we get concerned sometimes about some impingement, some pinching of muscles on the sciatic nerve right there. But that's it. It travels from the back out the pelvis and then between the sit bone and the upper leg bone. And so as we take a look, the sciatic nerve is also, it's the longest nerve in the body. It's, you know, as a nerve itself, it runs from the sacrum all the way to the feet. Really and truly, the fibers of that nerve actually originate in the brain itself. So that is a really long nerve. We do have one on each side of the body. We've got a left side and a right side. It splits at the back of the knee. And from there, it travels down the back of the calf to the heel. And then on the side of the calf, all the way down to the top of the foot. So you can have something going on in the back, and you can feel it all the way down into your foot and anywhere along the path. Sometimes that sort of thing even can make it numb or tingling through the work of the sciatic nerve. So who am I? A little bit of talk about me, and I won't stay on this very long. I got my physical therapy degree from Texas Tech University in 1994. So you do the math. I've been doing this for quite some time. I got my doctorate in physical therapy from the MGH Institute in Boston in 2012. During the past 10 years, I've authored the neuromuscular dry needling protocol. I lecture to a lot of clinicians and teaching the dry needling approach to pain management, and I do frequent guest lecturing at the collegiate level. Clinically, and these numbers need to be updated, but I've treated or supervised over 500,000 patient treatments during my time. From the dry needling standpoint, and I mentioned dry needling twice. We'll talk a little bit more about dry needling towards the end of the workshop. But I've dry needled well over 30,000 patients, and the number's probably closer to 150, 200,000 needles that I've used during treatment. So a little bit about back to normal. That's what our goal is. We want to get out of this pain cycle and get back to where we want to be able to do the things we want to do. And so, again, we talked a little bit earlier about, is your pain reproducible? Well, let's talk about traditional physical therapy. And what I mean by this is the sort of stuff that we learned in PT school. This is the basic entry level, and it's good stuff. Don't get me wrong. And I'll be honest, this is what I did for probably the first 10 years of my career, is just the things that we were taught. And you know, honestly, with this graph, what we look at, 25% of the patients that I saw with low back pain, sciatica type problems, we treated very successfully, didn't have to have any surgery, fully resolved their problem, and they were able to get back to normal and not have any further issues. Probably a full 50%, they did okay. I mean, they got exercise and things got stronger. They got a little bit more flexible, but they really never got a full grasp on their low back pain, their sciatica, the radiating symptoms, and they felt like, you know, they may still have to have surgery at some point. And then a full 25%, they just did poorly. They just didn't respond. And I got to looking at those numbers, and that is a sad state of affairs, that only 25% was effective in our treatment approach. So after working on my doctorate and looking at a lot of other continuing advanced education through some high-level clinicians, just across the U.S., but across the world, really honed in on and developed some really good skills on how to truly appreciate and treat that low back pain. So we'll talk a little bit later. The traditional physical therapy, for a lot of clinicians, a lot of my colleagues, this is still what goes on out there. Whether they're just not being taught well enough, whether it's just a lack of interest in learning and continuing to try to be the very best at what we do, that traditional approach is still the model that we tend to see more often than not out in the physical therapy world. So I look a little bit further, and after applying what I've learned and what I've developed myself and using my own approaches, I've started using these advanced techniques, and all of a sudden our numbers have changed significantly. So whenever we deal with a low back pain, a sciatic problem, anymore, 90% of the people that we see and that we treat, we can manage their symptoms and we can get them back to normal without surgery. We may have, and I'll be honest, there are probably 10% of people that are watching that are still going to have issues and ultimately may require some surgery. There are times when it is necessary, but by and large, using the advanced techniques that I've developed and that I've learned across the years, that 90% we can make a world of difference in dealing with their low back pain. All right, so we'll talk a little bit about the three main causes of back pain. Before we get to that, I want to talk a little bit about imaging. We get caught up with, both as clinicians, as patients, as physicians, we always get concerned about imaging, and imaging can be a fantastic tool. So let's look at what normal imaging looks like. So we're looking here at this particular person is standing and facing to the left of your screen. So the bones in the back are the bones that we feel whenever we run our finger down the middle of our back, and so they're facing the left. This is a pretty good looking image. It's not perfect. There's a little bit of some bulging down low, but by and large, this is about what normal would look like. So I get concerned whenever we talk about imaging. The person that belongs to this image, or the person this image that belongs to the person, although it looks good, this person could be having debilitating pain. They could be having 8 out of 10 pain. Unfortunately, the imaging doesn't show us pain. Imaging shows us what the structures look like right now, but it's not able to really identify pain. So we have to be careful when we're talking about normal and abnormal in imaging. So here we've got the vertebra. Stacked in between are the discs, adjacent to each other, and then right in the middle here we have the spinal cord. So one thing I'm going to do, and I'm going to pause just momentarily, at the end of this workshop, I'm going to be asking for people that are watching, if you want for me to take a look at what's going on with your back, I'm going to ask you to go to freebackscreen.com. And it says freebackscreen.com because it's exactly that. I'm here to take a little bit of time, look at your situation, see what's going on with you, get an idea of where we are. So that freebackscreen.com at the end, or if you want to go right now, go for it. But that's where I'm going to direct you to go to see if you want to look a little bit further at what's going on with you. So anyway, wanted to throw that out there before I got too far in here. So again, on imaging, what does normal look like? Well, if we take 100 MRIs of people over the age of 50, how many percent do we think would have a bulging disc? Well, surprisingly, it's about 80%, or 4 out of 5 people over the age of 50 on MRI have bulging discs. Now, here's the interesting part. They don't have any symptoms. So they're not dealing with any pain. They're not dealing with any numbness. They're not dealing with any tingling, anything like that. But yet on the MRI, they still have this bulging disc. So we look further. What about the percentage with stenosis? So stenosis, and we'll talk about this. Stenosis is just a narrowing of the hole where the nerve either goes through the spinal cord itself or goes out to the side to go into the legs or in the upper extremities into the arm. So what is the percentage with stenosis? With stenosis, it can be as high as 80 to even 95% of folks who have stenosis. And again, with this, they don't have any symptoms whatsoever. So what does that tell us? Well, that tells us that, again, we have to be cautious what we see on imaging. I have lots and lots of people who come to see me with back pain and back problems who tell me that they've got bulging in their disc, they've got stenosis, and they've got all this going on. Well, the person that came in with them, their spouse, their friend, their brother, good odds that person also has this same thing going on. They've got bulging discs, they've got stenosis, but they're not having symptoms. And truly, most people do have some bulging and some stenosis without any significant symptoms going on whatsoever. So that brings me up to this. We have to be careful of our vomit and our barf. And I just put this in here because it's kind of funny to illustrate the point of the imaging. The vomit is a victim of modern imaging technology and the brainless application of radiologic findings. So what does that mean? Treatment based on imaging findings alone without any clinical correlation. So we as clinicians, and because I deal with spine issues myself, and me as a patient, I have to be careful not to just get too excited or too concerned about what I'm seeing in that image, because what I really am concerned about is physically what's happening, mechanically what's happening in my body. And so we'll move from there. And again, I'm going to point out again that freebackscreen.com. As we move forward, just jot that down if you need to. I'll leave it up and we'll get to it at the end. So the three main causes of back pain, the first one, and this is not necessarily in order of significance or of numbers, but just the first one that I come to, the bulging or the herniated disc. We call it an HNP or a herniated nucleus pulposus. You don't have to remember that. So as we look at my little diagram here, and I'm going to go ahead, the yellow part here, consider that to be your spinal cord. Running all the way through the spine. Again, like the image we had earlier, this person is standing facing the left side of your screen. And so there we point out the vertebra. In between is the disc, and it's just sandwiched right there between those two discs. And this is a normal configuration right here. So a bulging disc, there's basically 4 different types of a bulging disc. The bulging disc itself is just a little herniation or a little pooch out of the disc. A lot of times it's fairly small. Sometimes it can be larger, but most of us have some sort of a bulging disc in this area. The second type is the herniated disc. And so here is where the annulus, or the outer rings, the outer fibers that hold that disc together, it starts to break down, and it makes it a little bit easier for that bulge to push out a little bit further. So a little bit of talk about, I mentioned the annulus and the nucleus pulposus. If we consider a disc is like if you consider a jelly-filled donut. Right around the edge, or the breading that keeps it together, is the annulus, and it's just a cross weave of collagen crisscrossed to hold that thing together. And in the middle is just the cream, or the jelly inside that. And so whenever the outer part of that donut gets a little bit thin, it's really easy for that jelly to push out of it a little bit. And so that's kind of the illustration there. So the second part is the herniated. Now, the good news is research tells us that if it's a bulging disc or a herniated disc, so even something like this, we can make a huge difference with these. That herniation, that bulge can be reduced. We've seen good research that shows us that. At a minimum, we know that if it's at this level, then we can show significant improvement in pain levels and function and mechanical movement. So that's the bulging and the herniated disc. Now let's get to the third and the fourth, which are extremely uncommon. The third is the ruptured disc, which is very rare. So a ruptured disc, quite honestly, the jelly from this donut will actually go through the breading, if you will, out into the spinal column itself. So that gets out there, and that's a problem. That very well likely should be, excuse me, should be surgical to take care of that. And lastly, which is extremely rare, is a sequestered disc. And that's where that jelly that's pooched out of the donut has actually broken off separate from the disc itself, and now it's just floating around inside the spinal column itself. Again, those two, probably not a lot that we can do from a physical therapy standpoint, but our bulges and our herniations, those are things that we can make some really good impact on. And so as we look a little bit closer, some imaging again. On the left-hand side, I'm showing a picture of a disc bulge. As you can see, this is down at L4, L5. And there is it's a little bit, it's not that significant. It's pushing on into the spinal column a little bit. It's not that significant. As we look at the image on the right, there's a little bit bigger of a bulge there. So just based on the size, we would refer to that as a herniation. That's pushed out a little bit. That outer annulus is broken down a little bit. And so that's what we're looking at with the bulge and the herniation. So coming back to our diagram here. The age. So the bulging or herniated disc, this tends to be a younger person's back issue. So it's usually under the age of 35, and you might ask why that is. So that jelly-filled donut when we're younger, let's say from 45 to 55 and younger, that jelly-filled donut, the jelly starts to get really hard. It loses its moisture content. And that donut all of a sudden almost becomes like a hockey puck instead of a cushiony donut. So at 35, that moisture will allow that herniation to push out, but it'll also enable it to push back in. when we get significantly older that we'll talk about, that doesn't happen quite as much. It's more of a sudden impact type of a situation. So anyway, the bulging herniated disc tends to happen for people who are 35 or younger. These folks have increased pain when they're bending or lifting, and they tend to have less pain if they're standing up tall. So this tends to radiate down the back of the leg. It can go all the way to the foot. And the most common level for the herniation is at L4, L5. And again, we looked at the 100 MRIs, folks over 50 here, and we know that 80% of folks with a herniation or a bulge are going to have, it's going to be 80% is the number of people, and again, they have no symptoms. So the second main cause of back pain, so this is the stenosis or arthritis or degenerative disc disease. This is our next age group. Stenosis, again, we talked about, is a narrowing of the hole where the nerves go down the spinal column or where they exit out to the side. So here, just a quick little look. Let me go back just a little bit. Okay, so again, we've got our pictures of our vertebra, our spinal cord, and our disc. Now, what's different here is the disc, but this person's a little bit older. Things are getting a little bit less moisture, and so that disc has started to compress down a little bit. So we're losing a little bit of height here. Well, when that happens, a couple of other things happen. We start to see some bone spurs, or what we call lipping, at the edges of the vertebra all the way around. And we'll look at an image in a little bit that demonstrates that. And so on the front side, it's not as significant of an issue. However, on the back side where the nerves exit and where the spinal column is, that then becomes a bigger issue, because normally we have a nice big amount of space here for all of those nerves to run through the spinal column and down out into the extremities. But whenever we have some of the bone spurs or the lipping, and whenever we lose some disc height, then and we will have a little bit more of the bulging that takes place as well, then we're going to see less space for those nerves. Then we're going to see some compression. So these folks, and this is my category, tend to be over the age of 50. They have more pain when they're standing and walking, and they have less pain with sitting. Here, the pain can be in the buttocks, it can travel down the side of the leg. This is frequently mistaken as hip pain. So I frequently have people that come into the office with a complaint of reaching out, and their pain is in their hip on the back side and over on the side. Well, more often than not, that is more of a back issue. It's more of a stenosis issue than it is an actual hip problem. Normally, our hip problems, we tend to feel those in the front aspect, or the front of the hip, as opposed to the side or the back. So these folks, if they lean forward, it will open the foramen and they'll have less pain. The foramen is where that nerve comes out. If they stand up tall, it closes it down, and so then they get a little bit more pain in that region. So let's look quickly at imaging. We talked a little bit about some lipping, and on the image on the left, this is some pretty significant lipping that's going on here. So this doesn't look like a great picture that we've got right here. You can see at different levels there's bulges, there's herniations that's pushed out into the spinal column. You can tell that where the vertebrae are normally, and the one on the right is decent. Normally have a decent amount of just shaped like a rectangle. These on this side, boy, they're starting to wear down, and there's not a whole lot of disc space in there anymore. The interesting thing is, I have a lot of folks that I look at imaging for, and you can have this image on the left and still have no pain. You can have no symptoms. I've seen people with problems much more, or imaging much more significant than this, and still don't have any symptoms. So again, we have to be cautious of what we interpret through that imaging. And then we'll move on to the picture on the right. And I use this one as an example. Now, the most common areas at L4, L5. This is bigger problem is at L5, S1. As you can see, there's a little bit of lipping on the back side. There's actually a fairly decent spur right there. And on the front side, there's also a fairly decent spur there. The whole spinal column is shifted back just a little bit. And then there is no disc left in between this at all. And so I bring this one up. This is an actual CT scan of my own spine. And so I use this as an illustration. I'm able to go exercise. I'm able to go jog when I want to. I can do most of the things that I want, and my pain stays very minimal as long as I will do the maintenance work that I need to do to take care of my own spine. Again, when I do mine, it takes me about 5 minutes, and that's all that it takes. But I have to commit to doing that, or I do get some pain back there. And so, again, my illustration of imaging, we have to be careful. So for stenosis and arthritis, degenerative joint disease, again, we've looked at our image of the compression because of all these things. Again, our most common level of stenosis is at L4, L5. The discs do shrink with age. I mean, there's nobody that's taller now than they were in their 20s or 30s. I've actually lost about 1.5 inches myself since I last measured as a younger person. These are our grocery cart folks. So you go to the grocery store and you see people pushing that cart around, and boy, they're just really leaned over on that. Well, their back hurts, and they're trying to limit and open up those framing back there so that the nerves can get some breath and have decreased pain. If they get really bad, they'll stop and they'll sit down. Most of the people that follow up with these workshops, a lot of us, we're dealing with this right here. Mine's a situation I deal with both this stenosis and with some herniation. My cause, my herniation started as a young person, and then it developed into stenosis over time. So you can have a little bit of all three. Again, we look at the MRI situation. Here, as we get a little bit older, up to 95% of us can have stenosis and still not have any symptoms. So now, the third cause, and again, I think I mentioned there's a lot of different potential causes for back pain, and I've lumped a lot together all in one place here. But the third piece is for the sacroiliac joint, or the SI joint. So if we consider a block or a stack of 5 blocks, I would ask, which one is the most important one to keep the block standing upright? Well, it's the bottom block. That bottom block sits in our spine on top of the sacrum, and together, this, which is L5 in the sacrum, is the keystone of the body. So if you look at architecture and where they've built archways, there's almost always a keystone in that archway, and that's because all the force is transmitted through there. Well, in our body, we have the same situation. The sacrum, which is the bones that we feel on the sides of our hips, they attach to this structure, to the sacrum itself, and that's what gives the structure and the support for the entire upper body through the lower body, and it's what helps transmit the forces from the legs all the way up into the torso. So there's a lot of stuff that happens right there at that sacroiliac joint. And so the joints themselves are located at the junction of the sacrum and the pelvis right there. So there's a lot of force taking place right there. So what are the ages for the SI joint problems? Well, this one can be anybody. Can be I've seen as young as 13 and as old as 85. Our causes for SI joint problems can be falls, different trauma, motor vehicle accidents, things like that, or very common for labor, especially hard, prolonged labor. These folks will have increased pain with sitting and position change. These also shift while standing. So whenever I do these workshops live in my clinic, you'll see me. I'm shifting around. I'm moving all over the place, and really, it's because I've learned over time that if I stand still for an extended period of time, then I'm going to start having some issue in mine is always my left SI joint, and so that's how you can tell if a person has that. Again, I'm actually one of those fortunate or unfortunate people who have a little bit of issue with all three of the main causes of back pain. But again, I take heart in that because we know that we can deal with these things. So here the pain can either wrap around to the groin or the thigh, or even out to the side of the leg. For some people, it doesn't move. It just stays with a thumbprint right in the middle back there. For a person that's got, say, a movement, a shift in the SI joint, that can make the leg feel heavy. So if you're one of the folks that you're sitting there and you notice that one leg always feels heavy, good odds it could be a sacroiliac joint or an SI joint problem. Imaging on the sacroiliac joint or the SI joint, unfortunately or fortunately, SI joint problems don't really show up on imaging. And if there is a tumor or there's a mass or something that really shows up there, that would be picked up, and that's critical to know. But for the dysfunction and problem that we have there, we just usually don't see anything of relevance on X-ray or MRI. Importantly to know for us as clinicians, most of the time if we're dealing with a person with a low back pain or sciatica problem and we just can't make any progress and treatment is failing, more times than not, the problem is in the SI joint. And so we've learned over development of these advanced techniques that we have to make sure that we're addressing that. With the exercises that I do at home myself, a lot of it is about the SI joint because that's really what can help keep that thing moving in a good position. Interestingly, 70% of people with an SI joint problem, it's a right-sided problem with forward rotation. Mine just happens to be left for whatever reason. So what does successful natural treatment look like? So those are the three main causes of back pain. We've talked a little bit about imaging. We've talked about what can be done even in spite of those things, that you can have the bad imaging and it still not create pain. So there's reason to have some hope that something can be done. And again, I'm going to point back to this freebackscreen.com. So what does successful natural treatment look like? Well, number one, if you've had some failed therapy in the past, after just doing some basic stretches, some exercises and so forth, and it didn't seem to get anywhere, well, probably the biggest reason is if they didn't do any hands-on movement. So successful treatment has to involve some sort of a hands-on maneuver with the spine and with the pelvis. We're trained, we can do adjustments, we can do manipulation if necessary. That's not necessary for everybody. Sometimes it's just getting that spine and the pelvis to move, either in the spinal segments themselves or down at the SI joint. So hands-on approach has to be taken. Second, we've got to have the strengthening exercises to stabilize the spine and pelvis. Stretching is important, but it's not as important as the strengthening piece. So a lot of times what happens is we want a quick fix for our back pain. And it doesn't even have to be back pain. It could be anywhere. The quick fix, I'm going to be honest, the quick fix usually doesn't work. We can knock pain down, and we're good at knocking pain down for a little bit of time, but the problem is it's a mechanical dysfunction, and if we don't address things through strengthening and flexibility to stabilize the spine, then the mechanical issue that caused the pain in the first place is going to come right back. The truth be told, the majority of the time, the issues related to spine problems are a mechanical dysfunction in the first place, and the longer that we live with those, the more that we're going to see loss of disc height, we're going to see more arthritis, we're going to see more bulging, and we're going to see more stenosis, but it's related to that mechanical issue that's going on in the spine itself. And so that's what we look at as a clinician. That's what I'm looking for, is what maybe the hamstrings are too tight. Maybe there's a little scoliosis. Maybe there's something going on that we need to make a little shift, but then we have to stabilize that through strengthening and adequate flexibility work. And again, the stretching has to be done. It's a really good way both to change muscle length, but also it's a really effective tool for relaxing the muscles. It's not a substitute for the strengthening piece because that's where we get normal movement back from. But the stretching is a key part. Another part that I really emphasize, especially if a person, let's say a person comes in and their pain is elevated, they're 5 out of 10, 6, 7 out of 10, or one of those high numbers where pain is really interfering with them being able to work on the mechanical process of how their spine works. Well, we don't want to spend 6, 7 treatments just trying to deal with pain. Number one, it takes too long. Number two, we're in pain. We don't want to mess with that. So I've looked around and I've found the best approaches to dealing with pain without using drugs or injections or surgery for that matter. And I've discovered I use both of these on myself. Dry needling is a fantastic way to break that pain cycle. There's something called a class 4 laser, which has been in use in the veterinary field for decades. And here recently it was approved by the FDA for us to use it for human use. And so those are really good, strong ways to get that pain knocked down. We've got to get that out of the way so we can get down to business. And again, we do that piece, then we can look at the hands-on PT approach, getting the strengthening in there to stabilize the spine and pelvis, and then the stretching to help maintain and relax those muscles. There are some times that all of these techniques don't work, and we have to try another approach. This is a time when we'll rely on our traction tables or decompression. It's not for everyone, and it's a passive approach. If you can get some relief through traction, or you may be more familiar with the inversion table, the teeter hang-up thing that you see on television. Our tables are definitely not that flimsy. We have full grade professional traction tables, but I don't like to use them if we don't have to, because again, it's a passive approach, and it can really help the pain. But if we use that as a substitute for strengthening and stretching, then it's just going to be a short-term fix. And I'm more looking to see if we can't get this knocked down and you functioning in a normal capacity again. So those are the 5 things of what successful natural treatment would look like. So here's what to do next. You've taken your time, you've come in and you've listened to me ramble on and talk about low back pain and sciatica. You've listened to me talk about the freebackscreen.com. So this is what I want you to do right now. So people who want treatment right now, if your pain is a 5 or 10 or more, we need to talk about setting you up for a PT evaluation. There's absolutely no reason for a person to be walking around with pain this high. So we'll talk about a PT evaluation for that. If you maybe want help in the future, maybe your pain is just a 2 or a 3 out of 10. That's still higher than we want it, but it's manageable. We can live with that. And in that case, maybe a free screen is appropriate. And in the case of a free screen, we'll talk about these in a minute. I can give you some things to work on that you can try to see if you can get that pain on down even further. So we're going to talk about, we want to go to freebackscreen.com for that, or our numbers are there. And at the end of this, I'm going to leave this screen up so that you can look at it and reference these things. If you go to freebackscreen.com, what you're going to see is a page right here. And all you have to do, throw your first name in there, your email, a phone number, and then one of either Casey or somebody will call you and get your information, and we'll set up a time either for the free screen and we'll talk about that, or if you want to just go ahead and jump into an evaluation and a treatment approach, we can do that. But that's what that first screen is going to look like. So my offer, I only do free consultations to people who come do the workshop. Again, you've taken your time to listen to me ramble on, and I can do it for a long time. So let's talk about this. On a free consultation, what you're going to get is we're going to look at certain movements. I'm going to feel your back, and we're going to determine what's going on causing your back pain and sciatica if you're having the sciatica. We want to figure out if there's something that can be done to heal it naturally. Again, 90% of the people we can make a big difference on. There's only 10% that we don't seem to be effective with. So those are some pretty good odds. So when we do that, see if there's something we can do, then I'm going to give you some tips. Maybe it's go home and start working on this stretch, or go work on this exercise. So I'm going to give you some things that you can work on. At the end of the day, we finish the free screen. If you decide that you want my help, then so be it. We'll do that. If you're not, I'm not trying to sell you on it. The whole goal here is just to give you information on what's going on with your back and what you can do to handle it. So just really briefly, the difference between a free consultation and a full physical therapy evaluation. Honestly, it comes down to the time. Free consultation, I'm going to take maybe 15, 20 minutes. We're going to see if we can determine a potential cause. We're going to look at what successful treatment might look like. In a physical therapy evaluation, we're going to take probably 45 minutes up to an hour. We're just one-on-one. We're going to see if we can identify the cause, mechanically, what's going on, what are we dealing with. We're going to go into apply successful treatment. If the pain is low enough, we may move straight into stretching and strengthening and stabilizing. If pain is elevated, we may have to drop down a little bit and deal with that pain. Bring that down either through some dry needling or the high-powered laser, some sort of way to get that process started. At the end, we'll sit down and we'll talk about what a plan of care looks like to treat your condition. Again, I talked about there are times that what we want is a quick fix. And sometimes we can do that, and that will really knock things out. We can see a person once or twice, and it's good. And honestly, sometimes we can. But the longer this problem has been going on, the more likely that it's going to take a little bit more time to get there. So on average, most of our patients that we see in the clinic We're there for probably for 4 weeks, 2 to 3 times a week, to really break that cycle of pain, to change the mechanics of what the body is doing, and then to get you in the habit of doing the exercises that you need to do to maintain that healthy back. So moving on one more time. So I've for this workshop, I've laid out 10 slots for a free consultation over the next week, and then 5 slots just for a physical therapy evaluation. If you would like to take one of those slots, you can indicate that in the little chat session at the bottom of the screen, or there's a Q&A. I'm also going to leave up this screen for a good little bit after we finish this workshop. But if you can't use that function there, just go to freebackscreen.com. I mean, the only people that know about this website is people who've come to the workshop. So I'll leave that up there for a little while. And if there are any questions through the Q&A that they weren't able to answer, then I'll bring Ashton back in and she can ask, and I'll see if I can answer those.
We did have one question that was, what is the standard length of time it takes to go through this treatment? Okay, so again, there are some people who we can treat, and if the person has been active and they had a weekend warrior thing and they had just a little sprain, that sort of person, you know, we can knock things down session 2 or 3 to get them back up to speed. Most of the people who are on this workshop are dealing with more chronic problems, and really and truly, those folks will take probably 4 weeks, 2 to 3 times a week, to get that pain knocked down, to get flexibility and strength restored where it needs to be, and then get that routine of doing the exercises at home that absolutely is necessary to maintain the function of the back. So I'm going to leave this on here for a little bit longer. Again, you can go to freebackscreen.com, or you can call or text us at the phone numbers there at either our Mineral Wells or our Weatherford office. And if you have any questions, feel free to let me know. I'll send an email out in the morning for those of you that got on, or maybe you got on a little bit late, or maybe you had to jump off. This is being recorded, so I'll send an email with a link to this recorded webinar as well. And so for the moment, I appreciate you coming and listening, and we will hope to see you soon.